name is Andrew Gao. Thank you for inviting me to present on this topic today. I'll be speaking about recent trends in refractive surgery. I practice at Empire Eye and Laser Center in Bakersfield, California, and I'm a comprehensive ophthalmologist with a focus on cataract and refractive surgery, as well as ocular oncology. So an introduction. So modern refractive surgery nowadays consists of laser vision correction, lens-based refractive surgery, as well as presbyopia correction. And these are the topics that we'll be discussing today. So I wanted to talk about issues in LVC, including safety of LASIK and PRK, barriers to laser vision correction, SMILE surgery, topography-guided LASIK, wavefront-guided LASIK, and presby LASIK. So every few years, reports surface regarding the risk or side effects of laser vision correction. Obviously, these issues have been known for a long time, but oftentimes in news media, these issues come up now and again. So for instance, there was an article in 2018 in the New York Times. Dr. Oz has reported on this on his show. And a few years ago, there was a very tragic story of a meteorologist from Michigan who committed suicide several months after SMILE surgery. Oftentimes, though, these anecdotal reports can be powerful because these are personal stories. People and families are affected. And so they can make quite an impression on the public. However, there are numerous studies that have shown the efficacy and safety of laser vision correction procedures. Recently, a few years ago, the PROW-1 and PROW-2 studies were conducted, which surveyed 574 total patients in the military as well as in the civilian population. Satisfaction rates of results of surgery range between 96 and 99%. There was a subset of patients who did experience new symptoms such as glare, halos, and dry eye up to 3 months after surgery. But the prevalence of these side effects decreased overall after LASIK and improved over time. In addition, these side effects did not affect patients' daily activities or their well-being. There were over 9,000 patients who participated in FDA clinical trials from 1993 to 2005, and there are over 7,000 peer-reviewed studies in the literature confirming the safety and efficacy of these procedures. However, patients should always discuss the procedure with their trusted ophthalmologist prior to surgery. Another barrier to laser vision correction is affordability of the procedure or cost. So the cost of this procedure can be daunting to some patients. However, if you look at inflation, LASIK is actually approximately 20% less expensive than it was 15 years ago. Nowadays as well, in the last few years, a lot of patient financing options have come up, including Care Credit, Cherry, Alpheon Credit, and others. And most of these companies embrace this buy now, pay later concept, which provides 0% financing for patients for shorter term loans. So the financial risk is taken on by these companies, the practice still gets paid, and the patients have the opportunity to break up the cost into smaller payments that they may be easier to afford. So another recent trend in laser vision correction is small incisional lenticule extraction, or SMILE. So this procedure utilizes a femtosecond laser to create a corneal lenticule, which is then extracted through a small incision and does not need a flap. This was FDA approved for spherical myopia in 2016 and myopic astigmatism in 2018. Currently, this is the fastest growing laser vision correction procedure. It's very common now in Asia, like in China, as well as in Europe, and gaining popularity in the United States. The visual results have been shown to be similar to LASIK, and there are fewer flap complications because there's no creation of a flap. In addition, studies have shown less post-op dryness and discomfort. There was a meta-analysis performed by Zhang et al. Of randomized controlled trials and comparative trials that compared SMILE with femtosecond laser, or LASIK. This meta-analysis found that there were similar visual results and better corneal sensation and tear breakup time in patients who underwent SMILE. Another randomized controlled trial comparing wavefront guided LASIK and SMILE in the fellow eyes found that a higher number of eyes had a better uncorrected distance visual acuity of better than 20/20, as well as improved low contrast uncorrected distance vision in patients with SMILE. Okay, another recent procedure that has been developed is topography guided LASIK. So this is made by Alcon and is called Contura. So this measurement device called the Wavelight Topolizer Vario measures topography and keratometry, which then allows for a wavefront optimization of the corneal optics and a custom treatment pattern for each patient. In the FDA clinical trial, almost 93% of eyes were able to achieve 20/20 or better uncorrected distance vision. A similar type of technology called wavefront guided LASIK from Johnson & Johnson uses the eye design, which is an aberrometer that was FDA approved in 2018. Wavefront technology is used in astronomy to improve image quality in telescopes by correcting the aberrations in mirrors and also aberrations induced by the atmosphere. So in wavefront guided LASIK, the laser can ablate a spatially variant pattern based on the measurements from the aberrometer. So it's a customized treatment for these patients. It combines the wavefront analysis with corneal topography to provide this custom treatment pattern for each patient. There was a paper at ASCRS in 2020, which compared patients treated with eye design versus WaveScan. There were about 100 eyes in each group, and the eye design eyes actually started more myopic on average, but more eyes were able to achieve a better final uncorrected distance vision than in the WaveScan group. There was another study that compared wavefront guided LASIK with eye design and WaveScan, and there were 59 eyes of 30 patients. A higher percentage of eyes were able to achieve a spherical equivalent within 1 diopter and also 0.5 diopters of ametropia in the eye design group, showing good results in vision after LASIK. A newer technology called Presby LASIK is something that was, the term was introduced by Ruiz in 1996. This procedure enhances the corneal depth of focus by creating a multifocal corneal surface. So this treatment, however, is pupil dependent and requires really good centration on the pupil. Otherwise, it can result in higher order aberrations such as coma. So there are various forms of Presby LASIK. In central Presby LASIK, there's a central steep area for the near vision and a peripheral flatter zone for distance. So examples of this would include Custom View Vizx, SuperCore, and Presby Max. There's also another technique called peripheral Presby LASIK, in which the near zone is in the periphery and the central zone is for far vision. Indications for this procedure would include early presbyopes between the ages of 40 to 55, patients with previously implanted monofocal IOLs who now desire some multifocality. Contraindications would include thin central corneal thickness or keratoconus, prior corneal surgery, ocular comorbidities, and patients over 60 who are phakic. So there in a clinical trial, researchers looked at outcomes including loss of 2 lines of uncorrected distance vision, which ranged up to 28%. There was a retreatment rate from 2 to 28%, and approximately half to up to 93% of patients achieved spectacle independence after LASIK. However, this procedure is still early and needs more research and longer follow-up times to determine the efficacy and safety. So that covers laser vision correction for refractive surgery. So now we'll talk about what's new in lens-based refractive surgery. And I think this is really where a lot of focus has gone in the last few years. So in this section, we'll talk about phakic IOLs, refractive lens exchange, and refractive cataract surgery. So phakic IOLs were first placed in the anterior chamber angle in 1953 by Strampelli. Dr. Wurst introduced the iris claw IOL in 1977, and then posterior chamber phakic IOLs were introduced by Fyodorov in 1986. Currently, there are 2 phakic IOLs available in the United States. The first one is the Vizient Implantable Collamer Lens, or ICL, made by Star Surgical. And their newest version, the EVO ICL, was approved by the FDA in March 2022. In addition, the Verisize, also known as the Artisan lens in Europe, made by Johnson & Johnson Vision, is also available in the United States. So first we'll talk about the Verisize. This is a PMMA lens, and it's often referred to as an iris claw IOL. It's designed for implantation in the anterior chamber and does require creation of a PI, or peripheral iridotomy, for prevention of reverse pupillary block. It's indicated by the FDA for correction of myopia from -5 to -20 diopters with less than or equal to 2.5 diopters of astigmatism and an AC depth of 3.2 millimeters. Contraindications include patients less than 21 years of age, shallow chamber, abnormal iris or cornea, pregnant and nursing patients, and a decreased endothelial cell count. In the FDA clinical trial, they looked at 662 total patients. At 1 year, 94% of the 204 patients were 20/40 or better, and 47% had uncorrected distance vision of 20/20. 94.5% were within 1 diopter of emetropia. Adverse events in this trial included surgical reintervention for lens exchange, lens reattachment, retinal repair, IOP spikes, and endothelial cell loss of greater than 1.8% per year. Going back briefly, so the implantation of this lens involves the enclavation or attachment of the iris into the iris claw. So sometimes this can become dislodged, or if it's decentered, that can affect the vision. So that's what the lens exchange or reattachment would be indicated for. The Visian ICL is a lens that's made out of a flexible material called Collamer. This is a copolymer of hydroxyethyl methacrylate and porcine collagen. The EVO and the EVO Plus ICL has a central hole, you can see here, which precludes the need for peripheral iridotomy. This lens is placed in the posterior chamber, in the ciliary sulcus essentially, between the crystalline lens and the iris. This is indicated for the correction or reduction of myopic astigmatism from -3 to -20 diopters, with 1 to 4 diopters of astigmatism at the spectacle plane. In addition, patients should have an AC depth of greater than 3 millimeters and a stable refractive history. Similar to the Verisize, this lens is contraindicated in patients with a shallow chamber, narrow angle, who, if they're pregnant or nursing, less than 21 years of age, have moderate or severe glaucoma, or decreased endothelial cell count. In the FDA clinical trial for the EVO, they followed 327 patients and 629 eyes for 6 months. No patients required a PI. 97% of eyes had less than 10% loss of endothelial cell count, and 21% of eyes had an increased IOP postoperatively, 3 eyes with higher endothelial cell count loss, 3 eyes with retinal tear or retinal detachment, and 1 eye had an IOL removal secondary to glare and halos. No eyes developed cataract or CME in the 6-month post-op period, and 90.5% of eyes were within half diopter of emestropia, and almost 99% of eyes within 1 diopter, which are results similar to LASIK and SMILE. So the EVO Plus Visian with an EDOF or EDOF ICL is based on the EVO Plus backbone with a central hole to prevent the need for a PI, and it has an aspheric design, which is designed to provide up to 2 diopters of extended depth of focus. A multi-center trial was conducted with 35 subjects implanted bilaterally. There was 1 patient who had a lens explanted due to dissatisfaction with their distance vision. The primary endpoint was uncorrected near vision of 20/40 or better at 40 centimeters at 6 months post-op, and 97% of these eyes achieved this endpoint. Over 90% of patients were satisfied with their vision, and they did not note any serious adverse effects in this small trial. Refractive lens exchange is another procedure that has gained more traction recently in some of these patients who are not candidates for laser vision correction. So refractive lens exchange is basically a variation of cataract surgery where the crystalline lens is removed in the absence of a cataract, as well as concurrent abnormal ocular anatomy that results in high refractive error. And usually a presbyopia correcting IOL is placed to reduce the need for spectacles after surgery. So patients need to be selected very carefully for this procedure. Age is probably the most important factor. So patients who have not yet experienced presbyopia are usually not candidates for refractive lens exchange. So for instance, a patient who is myopic, maybe a -10, but only 35, and they're not yet presbyopic would not be a good candidate for this procedure. Or on the opposite spectrum, someone who's a +2 hyperope, who still does well with glasses and doesn't need bifocals or progressives would not be a good candidate. In myopes, we do have to take caution for risk of retinal detachment. And in presbyopes, so again, a plano presbyope, for instance, may require another procedure to achieve their preoperative visual acuity. Oftentimes after cataract surgery or sometimes after cataract surgery, their vision may not be as good as it was preoperatively. Other considerations for patient selection include preoperative counseling on dysphotopsias or optical aberrations that may result, asthenopia or blurred vision, patient expectations, and possible need for readers, depending on what lens option is chosen and their visual results. In addition, patients who have occupations that are demanding on vision, as well as for near work, such as artists or engineers or pilots, you should really take caution in terms of selecting these patients for refractive lens exchange. Lastly, patients should not have comorbid ocular conditions that might limit their visual potential. For instance, age-related macular degeneration, diabetic retinopathy, glaucoma, corneal disease, or prior refractive surgery. There was an analysis of 280,000 cases reported to the European Registry of Quality Outcomes for Cataract and Refractive Surgery in 2014 and 2015. They found that 73% of these patients achieved biometry or prediction error within a half diopter and 93% within one diopter. This is similar to other studies looking at multiple IOL formulas. I bring this up because, when we look back at what we talked about earlier, in LASIK and SMILE with these laser vision correction options, the rate of success of achieving vision within half a diopter, one diopter of emmetropia is quite high, above 90%. So if we're looking at only 73% of sort of success rates achieving the vision close to emmetropia, that may not be satisfactory for patients. If the purpose of doing a refractive lens exchange is reduce their spectacle dependence, and we're not quite doing that, or there's a lower chance of doing that, patients may not be happy. Even with modern IOL formulas, such as the Barrett 2, only approximately 80% of eyes achieve refractive error within a half diopter of their intended target. And there are various risk factors for postoperative refractive error, including a poor preoperative best corrected distance vision, ocular surface disease, prior eye surgery, and irregular astigmatism. Posterior cornea calculations, I just wanted to show here. So previously, things like posterior cornea effective lens position need to be estimated. And in the ECERS 2018 clinical survey, only 65% of surgeons considered it in their toric power calculations. And in the ASCRS 2018 clinical survey, only 17% or 17% of respondents did not think it was clinically significant. And 35% thought there was no good way of measuring it. And 29% actually didn't even know how to calculate PCA or understand its significance. I think it's becoming more prevalent now, though. So for instance, like the IOL Master 700 and various other new biometers have PCA either already calculated or measured directly and incorporated into their formulas. As for intraoperative aberrometry, which is potentially useful, intraoperatively to determine accurate lens powers, only about 60% of respondents in these surveys stated they have no plans to use it, and only 3% of respondents currently use it on all cataract patients. I actually don't use intraoperative aberrometry, but I know some of my colleagues do use it, and they find it helpful in certain cases. So now I want to talk about presbyopia correction in the setting of refractive cataract surgery. So why correct presbyopia, with a multifocal or an extended depth of focus lens? Well, numerous studies have shown that there is an increased risk of falls with the use of bifocal glasses, including after cataract surgery when patients are corrected for monofocal distance. The fall risk may be due to a reduced inferior field of view, increased blur, reduced depth perception, and also reduced contrast sensitivity when they're looking through the near ad portion of the glasses. So there are various ways, various lens options for correcting presbyopia during cataract surgery. So first are the diffractive IOLs. So the Restore lens from Alcon was the first diffractive IOL in 2005 with a central area correcting for near and diffractive peripheral rings. And this would provide anywhere from 2.5 to 4 diopters of near range. The Technis lens from J&J has an aspheric anterior surface and a posterior surface with diffractive rings, as seen in the image on right. And this would correct anywhere from 2.75 to 4 diopters of near range. These lenses were essentially more like bifocal lenses, or are more like bifocal lenses. They provide good near and distance vision, but poor intermediate vision. In addition, there is a relatively high incidence of side effects, such as halos, glare, reduced contrast sensitivity. I think that the prevalence of these lenses has really decreased in the last few years with a newer availability of EDOF and trifocal IOLs, which we'll discuss further. Trifocal IOLs include the Panoptix from Alcon. This is the first trifocal IOL that was FDA approved in the United States. It splits light, so a quarter of it is at near, a quarter of it is for intermediate, and half the light is for the distance range. Over various clinical trials, over 85% of patients have achieved spectacle independence with this lens. Anywhere from 79 to 87% of patients achieved uncorrected distance vision of 20/20 or better in a review of studies. Patients often experience halos, glare, and night driving difficulty, but these usually improve with neuroadaptation over the first few months of healing. Extended depth of focus IOLs include the Tecnis Symphony from Johnson & Johnson. This was the first FDA-approved EDOF IOL in July of 2016. This one also has posterior echolets, which create an achromatic diffractive pattern that essentially elongates the focal point as opposed to splitting light. It also compensates for the chromatic aberration of the cornea to improve visual quality. Nearly all of the light is transmitted through the IOL, and so this may result in a decreased concern for reduced contrast sensitivity that you might have with more traditional diffractive IOLs or trifocal IOLs. Various studies have also shown better uncorrected distance, intermediate, and near vision compared to a monofocal Tecnis CCBU. In a large multi-center trial, over 85% of patients achieved spectacle independence, with over 90% experiencing no or mild halos, glare, and starbursts. Another EDOF IOL that is available now is the Vivity lens from Alcon. This was FDA approved in March of 2020. This uses a novel non-diffractive design that they call X-Wave that results in wavefront shaping. So light entering the eye is confined to a region in the extended depth of focus channel and results in range of vision. The presence of glare and halo symptoms is similar to a monofocal lens. In the FDA pivotal trial, it showed a distance vision of 20/25 or better for 89% of patients, and intermediate and near vision of 20/25 and 20/40 vision respectively for about 40% of patients. Another EDOF IOL that has a pinhole is called the Apthera lens from AcuFocus. I think it was formerly known as the IC8. This is based on the pinhole effect, which allows central light rays to enter the eye while eliminating diverging rays. So this reduces the size of the circle of confusion on the retina, which increases depth of field. This was FDA approved in July 2022 and is designed for an aim of a refractive target of minus 0.75 diopters in the non-dominant eye with a plano aim with a monofocal or toric monofocal in the dominant eye. The central aperture you see there is about 1.36 millimeters in diameter, and the outer diameter of the black ring is 3.2 millimeters. In the FDA pivotal trial, there were 453 subjects in total, and 343 of them received Apthera in the eye, in one eye, the non-dominant, and the monofocal or monofocal toric in the fellow eye. 110 of the patients in this study received the monofocal or toric monofocal in both eyes. The treated eyes with the Apthera had 2 diopters of extended depth of focus. The distance vision was equivalent to the control, and the intermediate and near vision was superior to the control. So this is a pretty exciting technology that will be coming out probably next year, available for use. And I think this has applications for patients with irregular corneas who may not otherwise be good candidates for diffractive type multifocal or EDOF lenses. A hybrid EDOF IOL is the Synergy lens from Johnson & Johnson. So this is a hybrid EDOF and multifocal lens, which provides a wide range of continuous vision with excellent near vision. This was FDA approved in May 2021. This contains the violet light filter I talked about earlier called OptiBlue, as well as high definition lathing, which helped decrease the nighttime halos and starbursts that patients experience. There was a 6-month multi-center clinical trial for 272 patients that compared the Synergy with a Tecnis monofocal. The Synergy resulted in 3.5 diopters of range of vision, with 88% of patients needing spectacles, quote unquote, none of the time at all distances. For this lens, there's a slightly smaller landing zone for the refractive target, so it's important to try to hit the refractive target as close as possible to plano and aiming slightly hyperopic rather than myopic for the best vision results. With the EDOF lenses like the Symphony, the defocus curve is quite broad, and so that can provide a slightly softer landing zone for patients, and usually we tend to aim first a hyperopic result if possible. So now we'll discuss some monofocal IOLs, but that do have some range of vision as well. So the first one we'll discuss is the Eyehance from Johnson & Johnson. This is a one-piece monofocal, which has an aspheric anterior surface and provides up to, or maybe even a little more, of half diopter of better range for intermediate distance. This lens can be a good compromise for patients who might not otherwise be good candidates for presbyopia correction due to other ocular comorbidities as well, such as glaucoma or maybe even diabetic retinopathy, because it can provide some intermediate range of vision. Patients with smaller pupils actually might have the most range due to the central location of the aspheric surface of the lens. And multiple studies have found comparable vision to the monofocal lens at distance and improved vision at intermediate and near, as we would expect from that defocus curve there. Another monofocal IOL is the Ray 1 EMV from Rayner. This is a preloaded non-diffractive monofocal IOL, FDA approved in March of 2021. This also has an aspheric anterior surface, which adds to the positive spherical aberration of the cornea and thus enhances depth of focus. In a small trial, there were 22 eyes of 11 patients, and they were found to be spectacle-free for distance and intermediate at 6 months post-op. Recently, there was a recall in May of 2022 for 2 of the IOL powers due to mislabeled packaging. Another option for correcting presbyopia is monovision. So this is, a bit older technology, so maybe not a recent trend necessarily, but can still be a great option for some patients, especially with some of these enhanced monofocals, which might provide some range of vision and again, a softer landing zone to hit the refractive target. So the reason I still use monovision in my practice for some patients is that premium IOLs may be out of reach financially for some patients. Now, with some of those financing options we talked about earlier, that may make it easier for patients, but so a lot of seniors are still living on fixed incomes, and so premium IOLs might be a little bit too expensive for them. In monovision, one eye, usually the dominant one, is corrected for distance, and one eye is corrected for near, usually the non-dominant eye. This is what's known as conventional monovision. However, some patients experience cross monovision, where the non-dominant eye is corrected for distance, and they do well. And other patients utilize hybrid monovision, where a multifocal IOL can be placed in a non-dominant eye and a monofocal distance lens in the dominant eye. As I mentioned, monovision can still be a great option for some patients to reduce spectacle independence after they have cataract surgery. I really only use it in patients who have trialed it in the past with contact lenses, or if they had LASIK 20 years ago to achieve monovision and they like it and do well with it. Maintaining monovision after cataract surgery, I think, is a great option for them. There's a study of 13,000 patients at a single center which showed no increase in fall risk with pseudophakic monovision. And that is a small, this still is a risk. You lose depth perception with monovision. But in this study, they found that there was really no increase in fall risk with monovision after cataract surgery. Another prospective cohort study of 56 patients undergoing mini monovision, where the near eye is corrected to minus 0.75 to minus 1.75 diopters of myopia, demonstrated high patient satisfaction, and only 9% of patients needed to use spectacles for reading and 18% for night driving. Mini monovision has also been used by a lot of refractive surgeons with EDOF lenses. For instance, they'll aim for plano in the dominant eye and maybe minus 0.5 to minus 0.75 for patients who desire a little better near vision with an EDOF lens. There's also a systematic review of 30 studies in the literature, which demonstrated good visual outcomes with fewer dysphotopsia symptoms than with multifocal IOLs. Patient satisfaction and spectacle independence rates were high in the study. A few studies indicated a decrease in stereo acuity or contrast sensitivity. But again, patient selection is really important for successful outcomes. If someone's coming in myopic or plano or hyperopic in both eyes, and you just decide to do monovision, there may not be a good success rate afterwards if they haven't trialed it previously. Another monofocal lens that's available now and has been very exciting over the last couple of years is a light adjustable lens from RX Sight. This is a 3-piece foldable photorefractive silicone monofocal IOL available in a range of plus 10 to plus 30 diopters. And this can actually be modified after cataract surgery by up to 2 diopters in sphere and 3 diopters in cylinder. This allows for the adjustment of the refractive power of the optic to adjust for the refractive error due to maybe unexpected changes in effective lens position or incisional healing. So basically, this lens can be changed after cataract surgery to adjust for any residual refractive error. The way this works is that 10% of the lens material actually contains a photosensitive material that's not polymerized. By shining UV light on it, it can change the positioning of these molecules and then polymerize the material to lock in the refractive power. So light adjustments are done with a very specific wavelength of UV light at 365 nanometers. It's FDA approved for 3 to 4 treatments over a 1 to 2 week period, anywhere 2 to 3 weeks after surgery. And then a lock-in treatment is done to finalize the prescription. Because the light adjustments are done with UV light and the lock-in is done with UV light, patients have to limit their exposure to ambient UV light during this pre-lock-in period by wearing UV blocking glasses really indoors and out. In addition, the adjustment visits can be a little longer. They require refraction every time and also measurements before and after dilation in order to make adjustments for the treatment. There are a few benefits to the light adjustable lens. There's a short learning curve for the physician. The surgery itself is a standard cataract surgery, and the light delivery device appears similar to the setup for a YAG laser. In addition, it provides great benefits for the patient. There are accurate and precise results. In the FDA pivotal trial, 91.8% of the 600 patients achieved refractive results within a half diopter of the intended target. So that's great results compared to the 73% I talked about earlier with just kind of standard IOL formulas. And long-term results in the 7-year follow-up trial showed stable refraction and good vision in 103 eyes of 61 patients. Some limitations to the lens, though. As I mentioned before, there are numerous visits required for adjustments as well as the lock-in treatment when one could potentially correct any residual refractive error with laser vision correction. In addition, the patient must dilate really well, like over 7 millimeters for treatment, because the photosensitive molecules extend all the way out to 6 millimeters in the optic. And so you really need to have a great view of the entire lens to utilize all those molecules and finally lock in the treatment for the entire lens. And then lastly, the requirement for UV protection for several weeks after the initial surgery can be very inconvenient to patients. They have to wear UV protecting sunglasses all the time. And so that may not be amenable to patients with a more active lifestyle. So the last section of our talk, I wanted to talk about future directions in refractive surgery. So the first couple are something called laser-induced refractive index change, or LIRIC. The first application for this has been in the cornea and being developed by Vision. This involves a femtosecond laser at low energy levels to alter the corneal collagen structure to actually change the refractive index of the cornea. So this could be utilized to treat myopia, hyperopia, astigmatism, higher order aberrations, or even create a diffractive multifocal pattern. This laser only treats about a 10 micron depth of the cornea. In the first study, they looked at 27 patients, and they found that they were able to provide a 1.5 line benefit to distance-corrected near vision in these patients. And the effects have lasted up to 2 years in animal data so far. The same technology has been applied to IOLs by Perfect Lens. So again, it's a low-energy femtosecond laser, and this laser then hydrolyzes the IOL material, which increases the hydrophilicity of the material and causes a change in the refractive lens index of the lens itself. This can be used on both hydrophobic and hydrophilic IOLs, and interestingly, can be repeated. So it could be used to add or remove multifocality or EDOF treatments for dissatisfied patients. So you can have a monofocal lens that you implant, have patients trial an EDOF or multifocal pattern, and if you don't like it, you could actually reverse it potentially. Another way that some doctors have been thinking about adjusting refraction after surgery is a modular IOL. So these are IOLs that are composed of separate components, which then allow for easier or safer IOL exchange or removal after surgery. So the Gemini refractive capsule is being developed by Omega Ophthalmics. And this is a circular silicone polymer capsule with a 6 millimeter opening at both the top and bottom. Basically fills the capsular bag to maintain its shape, and it's designed to hold a single piece acrylic IOL and with a channel in the center that holds the haptics in a stable position. This could make IOL exchange easier so that as technologies advance, one could update IOLs. So for some of these patients who have refractive lens exchange at say age 50, they could have an EDOF lens or trifocal lens. But if there's some amazing technology 20 years later, they could then have that lens removed and exchanged if desired. In addition, this refractive capsule could be potentially used for drug delivery or biometrics like measuring IOP. So I think this is a really exciting field that's being developed here. The Juvene IOL from LensGen is a modular fluid optic IOL that actually changes shape. So this fills the capsular bag, the ciliary body acts on it, and the central optic can actually change shape like our natural lens does to allow for near vision. So they conducted a trial called the GRAIL study, looking at 27 patients, and these patients were able to have achieved 20/20 vision at distance, 20/25 at intermediate distance, and 20/40 at near. There's another analysis of 51 eyes, which showed good refractive stability after a year. A third modular IOL in development is the Harmony modular IOL system. So this consists of a hydrophobic acrylic base and a hydrophobic acrylic optic. The central optic, like the first modular IOL that we discussed, can be exchanged or even rotated in the case of like a toric IOL if needed. In addition, multifocality could be added or removed, similar to what we talked about earlier. So if a patient doesn't like a multifocal lens, they can have it removed and replaced with a monofocal. But this is a more safe option because you don't have to dissect as much of the capsular bag as you do currently with IOL exchanges. The last development here is the Adia Vision modular presbyopia correcting IOL, which is another shape-changing accommodating IOL. So basically this fills the capsular bag, the ciliary body acts on it, and the fluid optic is able to, the fluid base is able to change position, moving the optic forward or backward to provide a range of vision, like our natural lens does. So in summary, refractive surgery includes laser vision correction and lens-based surgery. New technologies are rapidly being developed for the correction of vision as well as presbyopia. There are new IOL technologies that result in better refractive outcomes and more independence from spectacles. And some of these new modular IOLs may allow for more flexible vision choices or updates in IOLs in the future. So thank you for your attention and looking forward to welcoming any questions that participants may have.
All right, so from East Coast Virginia to West Coast Bakersfield, California, Dr. Cow, it was great that we went back to the front of the eye, because let me tell you, we were in the retina just about an hour and a half ago, and I felt like I could really relate to what was going on, because I, as someone who deals with the cornea and refractive surgery, felt so comfortable listening to your talk. I learned a whole lot, and there was so much excitement and discussion between the audience members, not only having had some of the different surgical procedures, but that you really talked about and spent an equal amount of time between the cornea as well as intraocular options. And refractive surgery is exactly that. Cataract surgery and intraocular surgery is refractive, and there's so many growing options from the corneal perspective too. So let's start there. So let's talk about younger patients who come in for your, let's say routine eyes. There was a great question. Someone who's younger than 21 years old, and they've got a stable refraction. While it is not an FDA approved procedure, but for whatever reason, they're contact lens intolerant or such, would you consider performing LASIK or PRK in someone who's truly debilitated by their -7 refractive error?
Yeah, definitely. Both my partner and I are comfortable with that. There are some things that we want to look at for sure, make sure they have that stable refraction, at least for a couple of years, especially in that, age group. I think I saw in the chat you were mentioning, certain demographics, like if they're going into the military and they need correction of that vision, that's something to consider. I've had a couple of patients want to become like boxers, fighters. So that's something to consider as well. Maybe not LASIK for them, but yeah, so I think with a stable refraction, normal topography, if they're motivated, I think they can be good candidates. We definitely talk about that risk of, potential changes in the future, especially in women who may get pregnant later in life. So as long as they are willing to undergo those accept those risks, I think they can be good candidates for laser vision correction.
Yeah, and you bring up a great point. There was so much before in terms of the controversy between pregnancy and the change that can occur with pregnancy in the refraction. And I think some of that has been put to rest, and we recognize now that those changes seem to be more transient, and it's just around the time of the pregnancy, the hormones, the lactation. But oftentimes it does go back to what it seems to be pre-pregnancy for the most part. So I'm kind of looking for that sort of stabilization, and of course not doing anything while a patient is actively lactating or breastfeeding or pregnant. Is that rule of thumb for you? And what are your parameters for that?
Yeah, I totally agree. And we usually wait at least 3 months until they finish lactation, breastfeeding before we bring them back for, repeat testing. So we've had a few patients come in recently where they're 6 months pregnant or they're, 3 months postpartum. So, again, we go through our little spiel about, those temporary changes, and we'll usually bring them back about 3 months after they're finished with their breastfeeding.
And what do I before I know that ICL and considering an intraocular Comler lens, or I just call it a intraocular contact lens, just because it's easier for patients to understand, it was not as much of a viable or a practice builder because they had to have a PI beforehand,
Right.
and then the cost that was incurred. Now with Evo being available, and then the Joe Jonas campaign, and it just really it is so nice because there's been a great uptick. There have been over 1 million that have been successfully implanted. There's really not an IOP issue. We can take care of our patients. They have LASIK-like outcomes from day one. You know, they get to have that without having the concerns of the dry eye. Um, it is great as an addition to your armamentarium, especially for those who have kind of that irregular cornea. Do you find that is there going to be hope? Do you think that ICLs will continue to grow and be a viable option in a refractive surgery market like the US?
Oh, definitely. In our patient population, we've had quite a few patients who are outside the range of LASIK or even PRK. And yeah, if they have irregular corneas or a little bit of irregular topography, I think those are great candidates for ICL. And like you said, quick recovery, both vision, pain, patients have minimal inflammation. So I think that's a great option for a lot of these patients who are outside the range of laser vision correction.
Absolutely. So like your younger than 40-year-old who especially who are scared, like they didn't wear contact lenses and they're scared of anything coming towards their eye.
Yeah.
And the more we do, yes, while it's a little bit more of an expensive incurred, they get anesthesia. So
Yeah.
they love the idea that you know what? They don't have to be awake for the procedure. They get to be completely comfortable and
Yeah.
they'll have the LASIK-like outcomes where on day one, they'll be able to see just like they would have with LASIK, and they don't have to undergo two separate procedures, which is great. So
Exactly.
it is a welcomed addition, and I can't wait for it to become more mainstream. And I'm loving the uptick there. So
Yeah.
let's talk about like those patients who are that 40 to 50-year-old, right?
Yeah.
Now your emmetrope or your hyperopic patient versus your myopic patient, LASIK becomes more of a tricky and a longer conversation for our patients. They don't understand. A lot of these patients are coming in because they can't read with, glasses on and single vision, and it's just a much longer, discussion.
Yeah.
So for your emmetropic patient, or your hyperopic patient, at what age do you say LASIK, monovision LASIK versus refractive lens exchange?
Yeah. I mean, I would say at least, 40, 45 sort of. It definitely is a tricky sort of age group. So we don't have a definite cutoff, you know. It's really a conversation with the patient. How long have they been wearing glasses? You know, what is their occupation? How dependent are they on their near vision and all that stuff? So I would say for the emmetropes and hyperopes, especially if they're hyperopic, you know, +1, +2 already, I think refractive lens exchange is a great option. One of our optometrists actually, who is around 45, was a +150 hyperope, and she got synergies, you know, a few months ago, and she's loving it. You know, she can see 20/15, and she's J1, and sees better than she ever has in her life. So I think for her that was a great option. But another patient might do well with monovision LASIK if they're not kind of willing or nervous about intraocular surgery. But our optometrist who does refractive, you know, management with us was very eager to have you know, an EDOF lens, trifocal lens.
I love that you said that. Now, what if it was the same patient at 50? For me, once they hit 48 to 50,
Yeah.
I'm really saying no to hyperopic LASIK because
Oh,
we know that hyperopic LASIK can accelerate cataract formation in these patients, not so much myopic LASIK. And I think it's because the laser, since it's a peripheral laser in order to steepen the central cornea, that and literature does demonstrate and support the fact that it accelerates cataract formation in the 48 and above. I'm more hesitant, especially if I see any kind of lenticular change. I'm really saying you should at least consider RLE because there's not an increased risk of retinal detachment in this age group. What do you think of that older than 40, you know, as they get closer to 50? Are you also closer to recommending that refractive lens exchange for them?
oh, definitely, yeah. And I was actually in our practice, we don't do a lot of hyperopic LASIK, you know. So for us, really, hyperope in the you know 40s, mid 40s to early 50s, definitely RLE.
Yeah, right. Like, and this is, it's such a different mindset. It depends on where their prescription starts from, right? Because it's going to really depend on their profession and their starting baseline axial length. Because this conversation is also very different for the myope. Wouldn't you agree? So
Yes.
for the myope, tell me about your 40 to 50, 50 to 55, and older, what you would recommend, because I'm much more conservative in the myopic patient, especially the, you know, specifically the axial myope, because of
Yes.
the vitreous and the risk factors thereof.
Yeah. Again, you know, I think complicated discussion with every single patient, but I've actually done quite a few myopic LASIK procedures in the last couple of months for patients
Yeah.
in their mid to late 40s. And, you know, you talk to them about the need for reading glasses because that's a huge change for a lot of patients. But, you know, a lot of these patients are, for whatever reason, women, and they just want to wake up, be able to roll out of bed and take care of their kids, you know, without fumbling for glasses or looking for their contacts. And if they have to wear readers at work on the computer, like they're okay with that. So I make sure that they totally understand that concept before, you know, we go forward with that procedure. I think once you get into the, you know, slightly older range, like in the 50s, then we do start presenting, you know, refractive lens exchange, whether it's with presbyopia correcting lens or perhaps monovision. And especially if that's something they've tried before with contact lenses. But we're, you know, I think up to maybe age 50, I'm okay with doing, you know, myopic correction with LASIK or PRK in those patients.
I am too. And if I'm ever going to consider doing anything intraocular, I want to make sure that I see that vitreous floater. I would love to see a PVD because if I see a PVD, which often does occur earlier on in a more nearsighted patient, I feel like that's a protective factor. You know, then I feel like there's less traction against the retina, which is going to protect them from having any retinal issues.
Right.
So, you know, a different conversation. It really is going to depend on where they start from.
Yeah.
So, but we're so lucky, you know, that there are these growing options where there are less dysphotopsias. It's going to depend on the lifestyle. And you're right. And every patient, the discussion does take a little bit longer, but we are very fortunate. And we can do some of these trials with our collaborative ODs on what level of monovision to set them. So we just really appreciate your very thorough lecture and all that discussion. You can still see, I mean, I still see in the periphery over here all the excitement that's happening. So Dr. Cow, I think that you may be getting a lot of evaluations up and down the West Coast after today's lecture.
Well, I
So thank
appreciate
you
that.
very
Thank you for the
much.
nice comments.
And the raffle code is MGD, like meibomian gland dysfunction, MGD. And so thank you again. Have a wonderful Sunday and tell everyone at Empire I said hello.
Sounds good. All right, thanks, Dr. Yu. I appreciate the time and appreciate everyone's attention and comments.